And this is an example of one where I injected steroids. We come in from the side here and then try to get some steroids into this space in the hopes of calming inflammation. And in a predictable way, the patient prior to the procedure had a pain level of 3 out of 10, 10 out of 10 being worse. And then after the steroid injection for at least 2 weeks, they had 0 out of 10 pain. So that was a nice outcome that seemed to follow a predictable pattern. However, I'd say half of my work is easily complicated by cases like this, where this is a sagittal view of the lumbar spine. And here at L5S1 is a representation of a normal neural foramen with the nerve coming out from the side of the spine. So this is a leg nerve that has free passage down to the leg, but compare that to the level above, and what you see at L4-5 is a highly compromised neural foramen. So the nerve there is getting squished either by a herniated disc or facet disease. And we're again asked to inject steroids at that level with the hopes of helping that patient. And we do that. We do this transforaminal. So here you see a needle coming in and some radiopaque dye showing we've injected the medicine at the right location. But here's the patient's pain scores after the injection. So they were a 2 to begin with, and in fact, their pain started increasing. So sometimes we follow what we, an algorithm that we think will help, but invariably, I would say half the cases go like this, where either the patient has minimal or no relief, or perhaps even getting worse. So this is very frustrating to me, obviously, right? This is what I do for a living. And if I'm not helping patients, then I'm not doing a good job. So this is the number that kind of the community feels we are underserving our chronic pain patients. So about 70% of those suffering from chronic pain fail to achieve some reasonable relief with standard of care management. And I think it has a lot to do with our inability to pinpoint where the pain generation is coming from, and we need to do better. So is there a new approach that we can use? So one of the things for the past couple of decades is that morphologic imaging, such as imaging obtained with MRI or CT or X-rays, really doesn't cut it. It's not actually helping us, and it may be even misleading us. We need something where we can highlight molecular that occur at the site of pain generation. And so if we can exploit those molecular cellular differences using technology that's been kind of called molecular imaging, perhaps we could do better. So please bear with me with this kind of simplistic representation of the pain processing or the nociceptive pathway. So if we have pain somewhere in our spine, we have pain sensing nerves that generate an action potential. That action potential will go up, the peripheral nerve of the corticospinal thalamic tract, and then our brain senses that pain, and we react accordingly. And then the brain does a lot of work to modulate that pain response, also help us get into a safe place and avoid further damage. What a lot of really smart people over the past several decades have found, there are significant molecular, cellular, biochemical changes that occur at various points, including the site of sensation, but also in the dorsal root ganglia, the dorsal horn of the spinal cord, various centers in the brainstem, and then a large number of areas within the brain. I'm going to be kind of talking about our ability to exploit what's going on at the periphery. And over time, people have found that not only are nerves heavily involved in the sensation of chronic pain, but of course there's muscular tissue, synovium, blood vessels. What's really hot right now are the innate immune system. Of course, there are various peptides, cytokines, and neuropeptides. So if you could tag a molecule that would identify any of these kind of structures, perhaps you have a better way of identifying someone's pain. So the idea would be, let's say someone came in with left foot pain, you would inject this tracer that was specific, let's say, for a certain pain receptor. Of course, it would kind of swim around, and then you would place them in either a PET-CT or a PET-MR scanner, and lo and behold, the scan would show that maybe the pain generation was coming from the knee, not necessarily the foot. So one of the things we would do is then that would inform, your guidance of therapy to the knee rather than to the foot. So kind of give you more accurate representation of where the nociceptive behavior is going for. One of our imaging protocols here is shown in this slide, where we first, when we place these patients with chronic pain in the scanner, and just as I've kind of illustrated, just because you have knee pain doesn't mean you'll have pathology in the knee. It could actually be arising from the back. So we'll actually do a whole body sweep from head to toe. It takes about 20 minutes, and then we'll try to guess where their pain is actually located and do more high resolution image sequencing in the next kind of sweep, if you will. So it's more localized. If they had knee pain, we might image the ankle, the hip, so on and so forth, in a highly detailed manner with more high resolution MR protocols. Our group has been focusing on these radiotracers. I'm going to be speaking only to sigma-1 receptor, but there is already FDA-approved FDG, which has been the workhorse for cancer imaging. Cancer loves sugar, so fluorodeoxyglucose is an analog of sugar that's radio-labeled. And we can look at cancer, but we can also look at it as an inflammatory marker. So inflammation loves, it's very energy-dependent process, so it sucks in a lot of glucose or any analogs of glucose, and therefore we've been using that in the clinics. Sigma-1 receptor, of course, is the receptor that I'm going to be talking about shortly. It's also the license that PainVox has attained for imaging this receptor. And there are other ones that are kind of in the pipeline. Sodium fluoride has been long used to look at bone turnover and arthritis. And one of the reasons I came to Wisconsin is that they're making manganese, which is a calcium channel analog. So it mimics exactly where calcium's going. And then we have publications in a variety of pain syndromes, including pelvic pain, CRPS, CSF leak, variety of case reports, and more on coming. So what is the sigma-1 receptor, you might be asking? It's a chaperone protein whose expression is increased when a cell has increased electrical or signaling demands, especially due to painful inflammation. This is a cartoon I created to kind of help illustrate that. So normally a quiescent cell that's just kind of hanging out, not doing much, will have low copy numbers of the sigma-1 receptor, which is shown here as a blue structure, light blue structure. It hangs out in the endoplasmic reticulum at low levels, and it's usually coupled to one of these ion channels, a lot of them kind of voltage dependent, in the endoplasmic reticulum. Now, once there is some sort of painful injury or an inflammatory insult, we get an upregulation in the copy number of the sigma-1 receptor, and their big role initially has been thought to be to chaperone all these ion channels up to the plasma membrane so they can do what they do best, which is signaling, whether it has to do with action potentials or other messenger systems that are needed to be activated in the response to painful stimuli. One of the other interesting things is that it stays coupled to its chaperoned receptor or channel, and it itself is a receptor, so it has some binding sites. And if you antagonize these sigma-1 receptors, you can actually modulate the activity of these ion channels. So in general, blocking the sigma-1 receptor will actually decrease the activity of its companion ion channel, if you will, or adding an agonist to sigma-1 receptor will increase the activity level of these ion channels. So there's some interest in the pharmaceutical world to develop sigma-1 receptor antagonists as a treatment for pain. And there's already been a clinical trial for the treatment of chemotherapy-induced neuropathic pain, where it showed some benefit for patients receiving it. Again, just there's a number of references here where you can look at the biology of sigma-1 receptor, but it has a number of roles, including ion channel modulation, as I spoke to, NMDA receptor response, all of this leading to some sort of long-term potentiation and plasticity of the nervous system, spinal sensitization, and then ultimately pathologic pain. This is a molecule that was invented by my friend and colleague, Chris McCurdy, who's now at the University of Florida, Gainesville. Parent molecule is shown here. And then that molecule was radiolabeled by a smart group of radiochemists over at Stanford University. So they were able to radiofluorinate it and use it as an imaging agent. And it itself also acts as a therapeutic. So at least in preclinical models, it shows very good analgesic benefit for the patient. So it doubles both as a diagnostic and as the cold form would act as a therapeutic. With this particular radiotracer, we scanned 190 patients with pain and 10 asymptomatic individuals. In individuals receiving the PET-MR scan, 98% of those scans were positive compared to only 20% of the patients on MRI. So MRI was relatively insensitive to the PET scan, and this resulted in about 75% change in management of those 190 patients. And with those change in management, we had more than 40 patients receiving quite significant benefit. This story still remains to be told in the remaining patients since this is an evolving process. If you take asymptomatic volunteers, all of them had a pretty normal scan except for one patient who failed to tell us they were sore from wall climbing exercises the day before the scan. So a lot of his back muscles showed up positive, but he actually admitted that he was sore from yesterday's workout, and that ended up being kind of a positive in that case. When we initially embarked on trying to image his scan, one of the things we wanted to do is, of course, prove that someone who did have pain actually had a lesion that should correlate with that finding. So this is one of our early cases. This is a patient with a left sciatic nerve tumor, which was giving him quite painful left lower extremity pain. And from all the standard of care workup, it was decided this is probably the lesion. So this is an axial image to that neuroma. Compare that to the contralateral normal sciatic nerve over on the other side of the other leg. Here it is in the coronal plane. And then if we look at the PET image in the lower right corner, we can see the tracer avidly attaching to that tumor. And then the upper right image is a fused PET-MR image from the PET-MR scanner, showing that there's co-localization of the tracer to this tumor. This was subsequently removed, and the patient had complete pain relief following that. We also wanted to see if a patient who had a nerve lesion, this happens to be a neuroma, this one was non-painful. So a patient had undergone a sural nerve biopsy for determination of a cause of neuropathy in this patient. And following the biopsy, the patient developed a neuroma of the sural nerve. And this was non-painful, so I could actually go and mash on it, and patient would describe no pain. So his PET-MR scan showed that there was no uptake of this sigma-1 receptor radioligand in the tumor mass. And then this is actually a fused image of the PET and MR showing, again, no significant uptake of that tracer in a non-painful neuroma. Now I'm just going to show you some case examples. This patient had a few years of knee pain, actually 7 years of knee pain prior to coming to see us. She was a middle-aged woman who had knee pain, and she was thought to have chondromalacia patella by her surgeon, which is just a fancy term for arthritis of the cartilage of the kneecap. The MRI was was read as negative, but still the surgeon decided, well, your pain is sufficient enough, I'll go in and see what I can do. So he did what's called a retinacular release, which is a procedure used to relieve pressure off of the patella, hoping that would work. It did not work. Subsequently, there was ablation of the nerve that serves the knee, ablation of the common peroneal nerve. So if you ablate the nerve, you can remove all sensation from the knee, which is, quite I think, a brutal type of experience to go through, but that was the only thing they could offer her. So they did that. It worked for a few months, but as nerves do, it grew back, and she ended up having daily 8 out of 10, 10 out of 10 stabbing pain. She had difficulty walking, could not walk on stairs or on grass. This is her MRI. It was read as normal. In retrospect, you can actually see the pathology here, but there was nothing here at the MRI to contribute to. And this is her whole body sigma-1 receptor PET scan showing you there's some normal physiologic uptake in the lung in a variety of organs, but some uptake was seen in her thighs as well as in the symptomatic knee. If we look at a zoomed image, we can see there's quite a significant abnormality in the symptomatic knee. And then fused with the MR image, we see that this lesion occurred in the intracondylar notch. So we talked to the original surgeon who did the retinacular release, and he went and investigated her, and he ended up finding that under arthroscopy, there was significant inflammation here. He removed the offending inflammation and sent it to pathology. 30 days after her surgery, she said a lot has changed. Her pain level went down to a 2. She can walk downhill. She can walk on grass. 6 months after the surgery, pain she had is completely gone. She's done her physical therapy. She's never been able to say that she's been pain-free for the past several years. And then 18 months, I checked in with her. She's completely off her pen medications, had a complete return of her leg strength. She is very happy, of course, that she got better. This ended up being what the culprit was. It was basically a fat ball or a synovial lipoma, and it was inundated with inflammatory cells. This fat ball was getting, we think, scissored between the cruciate ligaments, which also live in the intracondylar notch, and just getting repeated microtrauma, which ultimately became the offending factor in this patient. In retrospect, if we look at the MR, that's probably what it was, but us radiologists don't know everything, and maybe that's what was in her joint that we now recognize as probably being an abnormal finding on MR as well. Again, just showing you what the pathology is. So she had the arthroscopy, so the top image is showing you an MR image of what that lesion probably was, and then you can see on the follow-up post-arthroscopy MR that offending lesion has been removed, both here in the sagittal plane as well as the axial plane, and it correlates with her having 0 pain at this time. Here's another example of another patient with knee pain. This patient underwent ACL reconstruction after an injury, and after the ACL reconstruction had excruciating, debilitating pain. This is their kind of pain diagram where they described all their pain, and again, in the left knee. This is a whole body PET study of the sigma-1 receptor radioligand. You can see there's quite a bit of uptake in that knee. These are just some static images. We're seeing a lot of uptake between the patella and the femoral condyles, as well as some spots behind the knee. Again, sagittal images showing the same, where we have substantial uptake throughout the knee in these spots here. I'm just kind of going through different slices across the knee to show you what this was. So it was thought to be a form of arthrofibrosis that had a lot of, had the ability to signal pain in this patient, or at least be painful in this patient. And the top row of images show you what we saw on an initial scan of this patient. A lot of uptake within the intra-articular space, what was thought to be painful arthrofibrosis. And then we managed to convince the surgeon to go in and remove that tissue. And then this is their post arthroscopy scans showing you successful removal of the material that was avid with the PET tracer. So, and this correlated with 0 out of 10 pain. And in fact, the patient who was quite athletic went back to working out and said, now this knee is stronger than the other knee. What's kind of unfortunate in this study is the patient who received the ACL reconstruction kept telling their surgeon that their knee was more painful than it was to begin with, and that surgeon didn't believe him and basically told him, you need to go see psychiatry because there's nothing else I can do after doing a repeat MR and showing that there was just normal post-surgical changes. And so patient was very frustrated, as you can imagine, until they got this scan. Sent me emails saying his knee is back to normal and stronger than the other knee. Myofascial pain syndrome. So this is a pain syndrome where your muscles, especially in your neck and upper back and maybe your mid back, may feel painful. And if you were to push your fingers into the muscles, you can actually trigger. So they call these trigger points. It's the disease where you have trigger point pain in your musculature, primarily in your neck or upper back, but it can actually be anywhere in your body. So here's a patient describing where their pain is. So on the back of their neck, it kind of radiated down their spine or just off the midline of their spine and down their arm. This is, again, a 28-year-old female with right point tenderness and right upper back pain. And these are scans of axial images through her neck. The upper left image has a green line showing you where the transverse or axial slices are obtained on the other images. If we look at this fluid-sensitive MR sequence, we see no abnormality. So on MR, and this is what she's been getting for years, is repeat MRIs show no abnormality in her neck. And sure enough, even the MR we perform on our PET MR showed no abnormality, no signal to suggest there's any inflammation of any particular muscle. But lo and behold, you get the sigma-1 receptor pain scan, and it shows uptake in specific muscles, shown here. These are coronal images now, just corroborating what we saw on the axial images, in particular muscles on the right side of her body. If you compare her left side, which is non-painful, there was no significant uptake. And then what do we do with this? Well, you can take her into the CT scanner knowing exactly what muscle it was and perform a dry needling procedure as well as injection of anesthetic and steroids. So this upper right image of this slide shows you where we place that needle. I've only flipped the image because the patient is actually prone when we do this procedure, but I'm just showing you in this orientation to kind of show you that it kind of corroborates where we saw her image, her painful foci on her PET image. Again, this is another trigger point about mid-cervical spine, so at the level between C4 and 5, and that showed some uptake here in a different muscle, and then we treated that as well. She's had multiple injections over the last several years, and she said she's never felt this good after injection. And these are typically done blindly in the clinic, so MD will insert a needle or a practitioner and try to guess where their trigger point is. But here we have precise localization and an excellent outcome because of this. Her pain kind of ranged from 6 out of 10 to 10 out of 10. She's had here a list of different injections, almost none of them really not providing much, any relief. So she was quite happy with that. There's some other applications. So I work with Dr. Wilson at Stanford. He is an expert in neurofibromatosis. These are painful and non-painful nerve tumors that some patients have. Quite an unfortunate syndrome, but one of the things he has to do is to have the ability to determine which tumor is painful versus non-painful. And a lot of these patients may come in with tens, if not hundreds, of these tumors. And if you take out the wrong tumor, you cause significant morbidity. So you would like a better way to determine which of the lesions, these nerve sheath tumors, are painful versus non-painful. This is an example of a tumor in the brachial plexus. So you're seeing the neck here and a tumor arising from the brachial plexus where the white arrows are pointing to. This is a non-painful nerve sheath tumor, and that kind of supports SUV measurement, so you can make standard uptake value measurements, which is relatively quantitative in PET scans, and show, okay, this is an SUV max of 1.3. Here's a painful one in the sciatic nerve. So we're down at the level of the lower pelvis, right at the top of the back of the thigh. This is a painful sciatic nerve tumor. This has an SUV max of 3.2. Here's some other examples for different patients. A painful one in the upper left corner, in the ulnar nerve, which is a nerve in the arm. Another one mildly painful. So it seems like the extent of SUV max can dictate or predict which tumor is painful versus non-painful. And he kind of developed a threshold that if it was a SUV max of greater than 3.1, you had a sensitivity of 100%, specificity of 87%, accuracy of almost 92%. Another last example here. This is a patient with an autoimmune rheumatologic condition called Sjogren's disease. Typically, they get dry eye, dry mouth, and dry skin, but it actually infects multiple organs, including muscles. And so they have autoantibodies, if you will, that attack their body. All of the MRs this patient had were negative, and her doctors were taking her less seriously since they couldn't really see a source of pain. This is where she draws her pain. So quite all over her body, as you can see, with circles and X's. And on the left image here is the sigma-1 receptor PET scan. Her whole body is basically lighting up. Again, her MRs have been negative over the last several years. And then just for comparison, just to show you what a patient on that's asymptomatic looks like, two of them just provided. Usually the legs are quite quiet, meaning they have low radiotracer uptake. But here are some sample images showing the distribution of this tracer with varying degrees of intensity in different muscle groups, which appear to correlate with her symptoms. So these are her neck and upper shoulders. This is the base of the neck, showing quite avid uptake. Notice on the lower left image is fluid-sensitive MR sequence. I don't see any edema or high signal in there where you'd expect, some inflammatory changes in something that. But the PET, of course, is 100 to 1,000 times more sensitive than MR, which is why we're seeing it with the PET scan. Back, so kind of thoracic area. These are pelvic girdle, so her gluteus maximus had some uptake. Just axial images through there, her thighs, quite rampant. Again, fluid-sensitive sequence in the lower left image showing basically a normal MRI. So she was very happy to get these results. These are emails between me and the patient. It's good for me to know where I hurt has an image correlate and that it's not all in my head as has been suggested. And as much as I am sad that my disease is so diffuse, I know that it is indeed real. So even from a emotional, mental kind of standpoint, these patients are getting some satisfaction knowing that they're not crazy, right? You help me more than you can know. So we have a lot of work to do ahead of us. I'm hoping PainVox can generate some support and funding to kind of carry this further and ultimately bring it to the masses. We need to, of course, do some proving a validation of this, but I think we're kind of already showing that it's helping a number of patients. A big challenge, of course, is getting physicians to kind of break from standard of care, but I think usually the younger generation docs are more amenable to that. So I've been partnering with those types of individuals. Pain can be present in the absence of morphologic changes. PET sensitivity can highlight pathology not normally seen by MRI as a result and provide personalized diagnosis and individualized management plans. MRI, in this case, does still provide an important role because it gives us kind of morphologic insight as to what might be the pin generator. In that first case, for example, I showed you, PET is teaching us what might be abnormal in MR when it's not really apparent to us. And I think this kind of approach will also enrich clinical trials appropriately. So if you want a certain type of pain patient that is affected in a certain part of their body, then this kind of approach might help select for those kind of patients more accurately than standard of care. And then I think whole body imaging is quite important since the symptoms may be a referred site relative to the actual pathologic site. A lot of people went to help do this, and thank you for your attention.